Hello, everyone, and welcome to another Lecturio webinar, this time titled Closing the Musculoskeletal Training Gap in Residency Education. It is my great honor and pleasure to introduce Dr. Stephen Holt, who is our speaker for the day. And if you have used the Lecturio platform in the past, you absolutely know who Dr. Holt is because he is one of our Lecturio educators in the videos. Today, our speaker is Dr. Stephen Holt, who's a medical education expert and an associate program director of Yale Primary Care Internal Medicine Residency Program. And Dr. Holt is also an expert in residency medical education and curriculum development with a focus on practical case-based musculoskeletal training. And as I said, he's one of our Lecturio educators, so you can see a lot of his videos on our platform hosted. My name is Dr. Goran Stevanovsky, and I will be your host for the event today.
Thanks so much. I'm going to take over the slides here. Hello, welcome. Honored to be here and excited to talk about this particular subject, which is really one of my absolute passions, is about bringing musculoskeletal training into residency program environments. I'm glad to have many of you here today. I do have a disclosure. I am a paid content creator, as Goran suggested, for Lecturio. So in many ways, I'm hopelessly biased in terms of supporting or promoting this musculoskeletal component of our physical examination course within Lecturio. But independent of that, my biases are I really want to promote musculoskeletal education in whatever domain or strategy you want to employ. It's something that I think is grossly lacking, as I'll get into. These are my objectives. We're going to talk about common musculoskeletal training gaps, learn how to design and implement a case-based musculoskeletal curriculum, exploring some strategies for combining self-directed learning with active workshop instruction, and then review some resources. As you might imagine, we'll certainly talk a little bit about Lecturio's platform. My learning objectives do not include how to bolster your own shoulder examination or knee examination, of course. So if you're hoping to learn how to improve your own musculoskeletal exam, I'm afraid you've come to the wrong place. At least this webinar will not meet that goal. In many ways, my talk today will be a little bit of a timeline of my own training and my own uh, cultivation of my own musculoskeletal skills and the development of the curriculum that we have here at Yale Primary Care Program. And so I'm going to sort of march through my own personal timeline and how I ended up where I am right now. I graduated from med school in 2004. I joined Yale's primary care internal medicine residency in 2004, and I completed my training in 2007, did a chief year, which wrapped up in 2008, and then I joined the faculty. And so I was working in the outpatient faculty practice, and it became very clear very quickly that, no surprise, musculoskeletal complaints are among the most common complaints that we see in primary care or in internal medicine writ large. And um, it's clear that it's something that patients are very concerned about. It's something that patients are oftentimes very frustrated about. And it's something that oftentimes patients like make demands on us as clinicians that we need to prescribe this medicine. We need to get this MRI. I need to see an orthopedist to address my acute, subacute, or chronic musculoskeletal pain complaint. And I know for myself, when I finished residency and now I'm out in the world seeing my own patients who are presenting, I felt like I was really good at doing insulin titration. I was good at managing hypertension. I was good at deciding what to do with somebody's abnormal LFTs. But when somebody had a shoulder complaint, I sort of knew what I'm supposed to do with doing a NEERS or a Hawkins test, and I knew kind of how to palpate different parts of the knee, but I never confidently felt like I was really addressing my patient's need. And I did not feel confident that I was making the right diagnosis. And more often than not, I found myself going through the motions and almost feeling like a charlatan because I just did not feel competent nor confident in my musculoskeletal exam, and found myself sending a lot of folks to get the MRI, see physical therapy, see orthopedics, etc., because I just wasn't confident in my own skills. So at this point, I'd love to take a quick pause and actually ask all of you. So first off, I think here comes the poll. Yeah. So the first question is, do you have a leadership role within your within the residency program of which you may be affiliated. And the reason I'm asking that question is because I'm curious how many of you are going to be deciders or have a role in the decisions that influence changes or an evolution in the musculoskeletal training within your residency program. And then the second question, which is sort of getting to what I was just talking about, is on a scale of 1 to 10, how comfortable are you right now in diagnosing musculoskeletal complaints in terms of relying upon your physical exam? So I'm curious to just sort of see where people are and if everybody was in the same boat I was, or if some folks feel more confident. So great, I'll give a minute for. It looks like there's 20 participants, so I'll give some time for those folks to answer this quick survey. So that's a healthy number. So it looks like more or less half of the folks on this Zoom have some leadership role within a residency program, and then a pretty wide range of comfort and competence with the musculoskeletal exam, ranging from a 3 out of 10 to a 10 out of 10. Kudos to you, 10 out of 10 person. I'm glad there are folks out there who do feel comfortable and confident with the MSK exam because it's such an important component of internal medicine or family medicine for that matter. Great. All right. I will end the poll there. Or I guess I'll leave someone else to end the poll. So in any event, so I found myself feeling a little at sea in this regard, and so I wanted to increase my skill set. And I will say that compounding this was increasing recognition that even if I did indulge that patient's request to get more advanced imaging, whether it was plain films, CT scans, or MRIs, I soon came to better appreciate that actually getting that MRI, while it may seem like you're doing the patient a service by further characterizing what is the source of their knee pain, shoulder pain, neck pain, etc., it turns out that actually we may be doing more harm than good when we indulge the patient's request to get more imaging. And in particular, this was a study done some time ago that looked at the incidence of incidental findings, basically. So this was a study that looked at 100 asymptomatic persons over the age of 40 who undergo a cervical MRI. So basically, these are folks who have no problems. They're out there, they're enjoying playing tennis or pickleball nowadays and not having any symptoms. You do an MRI on 100 of these people, and lo and behold, 57 of them have cervical spondylosis. That is some evidence of disc degeneration, facet joint arthropathy, bone spurs, things like that. And even worse, 28% of them had evidence of herniated discs and or spinal stenosis. These are people with no symptoms whatsoever. So imagine being in this study where you're just enrolled because you have no symptoms and you wanted to just participate in a little bit of medical research. You do the study, you find out, oh my God, I have spinal stenosis. Now you're very sad. Now you're sad because not only have you just been told you have this terrible pathology in your spine and you're anxious about the possibility that I could crick my neck the wrong way and become paralyzed, um, but basically you've been told you have things that maybe need to address even though you weren't having any symptoms. This type of study has been shown in other venues as well. So there was one that looked at 100 asymptomatic persons who had a knee MRI. Lo and behold, 36% of people had a meniscal tear. So what does this tell us? It tells us that just getting that MRI, while the patient may want it, and we may think, oh, well, it's going to provide the answer to whatever this person's pain complaint is, the reality is that as much as 36% of the time here, you're going to find things that have nothing to do with the patient's pain complaint because 36% of asymptomatic people have these very real findings on imaging. So if I don't feel comfortable in my exam and I just rely on radiologic testing, I'm actually doing my patient even more of a disservice because now I'm finding things that may even warrant intervention or may lead to an orthopedic intervention, but that actually don't correlate with the physical exam findings because I wasn't performing a good physical exam. So with all that in mind, I, I didn't want to feel this way. I didn't want to feel incompetent and not be confident in my exam. So I did what one did back in the year 2008. I purchased some physical exam textbooks, and I really enjoyed reading several, musculoskeletal textbooks, or even like Joseph Sapir's Art and Science of Physical Diagnosis and Klaus Beckup's review of musculoskeletal medicine. I'm not actually referring to these particular two textbooks, which I picked at random off of Amazon for this talk, but there's a host of different ways to sort of read about different conditions. But looking at these textbooks, I very quickly realized, like, well, yeah, that's a picture of how to do the resisted external rotation lag test. But a picture, it's a two-dimensional thing. It doesn't really tell me how much stress do I apply? Am I doing this right? Do I have the patient oriented in the right way? How do I interpret the test? Is it, if they have pain, is that the answer? Or is it that they feel some sense of laxity when I'm doing the maneuver? So the textbook itself wasn't really helping me to know how to perform the exam with a real person. Then I consulted some online resources, and back then and even today, Stanford School of Medicine had created the Stanford 25, which is a pretty solid set or collection of videos that get updated periodically. That's available for free, and it has it'll show a video of how to perform different parts of the exam, and then it has sort of a full page description of pitfalls and ways to interpret the test, etc. And they do that for all the different parts of the physical exam that you might imagine. And there certainly was a video for the knee exam. It still gets updated today, and they're homegrown kind of videos, but they're nice enough. But even watching the videos, it was the same thing. Even if I could see the exam being performed by people who were competent, I still didn't know if what I was doing was competent. Just like a gymnast can't really learn how to, work on the balance beam if there isn't a coach watching them, giving them direct feedback about the things they're not quite doing right. And there's no way that any athlete would perfect their skill of that particular sport by just watching videos. Videos may help and textbooks may help, but you need somebody giving you direct immediate feedback on how to improve your skill. That's called deliberate practice, which watching videos was just not successfully performing. So it got me thinking about what is the evidence looking at different strategies for teaching and learning the musculoskeletal exam. I already talked about textbooks. I talked about sort of watching lectures, whether it's videos of lectures or what have you, or maybe watching a lecture in a classroom. I certainly had some lectures in during my residency training by a rheumatologist talking about low back pain or things like that. But I'm sitting in a conference room watching that lecture. The other strategy is increased clinical exposure with real patients, and you have an attending physician who's taking you to the bedside. This is something that anyone who knows me or works closely with me here at Yale knows that I'm constantly, incessantly promoting bedside rounding as I think one of the most important skills, most important vehicles for role modeling how to manage patients with the full spectrum of conditions that we see in internal medicine, and not just the hands-on physical exam skills, but also the counseling and patient interview skills. So I'm a big fan of bedside rounding, and that's certainly a great place to cultivate your skills. But ultimately, I found that interactive workshops with hands-on practice, again, deliberate practice, where we have standardized patients and residents rotating from station to station and practicing the skills, getting immediate feedback, practicing the skills again, that was really the gold standard. That was the best way to really learn how to effectively cultivate a skill set making of diagnosing various musculoskeletal complaints that we see in primary care all the time. So with that in mind, I rolled out Yale Primary Care's musculoskeletal workshops. This is the version 1.0, and this was, I would say, 2009, 2010. And we basically, with the help of some chief residents that I was working with, we created this OSCE-based curriculum. And on a given ambulatory half day, we would have our residents watch me give a lecture. Let's say it was the knee exam lecture. They would watch me for 45 minutes or so, talk about the knee exam, and then we would immediately transition to a larger room with four stations, and at each station there was a different case of knee pain with a brief vignette. A person maybe who had had a sports-related injury the day before and was concerned about their, an MCL tear. Another patient maybe who was older who had sort of chronic pain that was waxing and waning, and they had a flare of osteoarthritis, and maybe another patient with Pessant-Serine bursitis, etc. And so they rotate from station to station, practice their exam skills on standardized patients. In this case, the standardized patients, let me just pull up my pointer here. My standardized patients were actually volunteer medical students, so that was pretty cool. And I had a faculty instructor set up at each station. And importantly, the residents were given deliberate practice with immediate feedback. And this was very well received, and really enjoyed doing it, and got a lot of great feedback about this approach. But I will say that it was a little tedious because it took a lot of time. I had to give these lectures, repeatedly for four different cohorts of residents going through, and I had to give this lecture multiple times for the different joint systems that were involved. And moreover, residents, let's say a month later, they see a patient in their clinic with shoulder pain. They didn't have anything to go back to because I had given a lecture live. And so they couldn't go back to that lecture. They couldn't go back in time and rewatch it again. And so I needed to come up with some way to have asynchronous learning going on. And likewise, um, I just found that if I was the only one teaching it, that wasn't great, because if I'm not there, or let's say a resident even missed that session for whatever reason, then they just never got the content at all. So with that in mind, we created YPC Musculoskeletal Workshops version 2. And this was, I would say, around 2011, 2012. I went ahead and recorded myself doing a series of videos. This is a picture of the shoulder video, and that's my much younger self shown there in the bottom right. And I basically, took pictures from different things online and tried to, make sure I read the evidence, and I really did get deep into the literature on which physical exam maneuvers had the best test characteristics, the best, positive and negative likelihood ratios for ruling in or ruling out certain conditions. And each of these lectures was sort of maybe 40 minutes long, and they were put into a shared folder that all residents could access at any time. And that was great. And we did that for basically the next almost 10 years, just using these videos, which I would periodically update. And they were, as you can sort of tell from that picture on the bottom, very homegrown basement kind of videos, no real bells and whistles. And again, the videos themselves typically weren't showing an exam being performed live, because I didn't have the savviness to sort of film myself live doing a video and making it look good. So I was mostly just borrowing 2D images, like you can sort of see here, showing certain maneuvers, and then hoping that at the workshop itself, with those four stations, that's where the learners would really learn how to do this stuff and get direct feedback on it. So in some ways, this was a flipped classroom model. The residents would watch the video in advance. I would tell them, basically, I'd tell them the Friday before, watch this video over the weekend. The workshop itself will happen on Monday. Residents would show up, and pretty consistently they did watch the video. And then we would do the deliberate practice with the OSCE workshop stations. OSCE, by the way, for those who don't know that term, objective structured clinical examination. It's just, a well-validated instrument for promoting the acquisition of skills, of medical skills, and other skills for that matter. All right, this was what the actual cases look like. So there's an instructor copy, and then there's a learner copy. The instructor copy describes what the objective is, what the actual diagnosis is for this particular case, which is case A. The diagnosis is going to be an osteoarthritis flare. And then this is the brief vignette. And this is basically what the resident gets. The resident gets this vignette. Mr. Richard states he has mild pain in his right knee intermittently for about 5 years, et cetera, et cetera, et cetera. A little bit of background, past medical history, and just a little bit of physical exam, generic stuff. And what the instructor gets and what the also standardized patient gets is the actual physical exam findings. So this is what they're actually going to see. This is what the instructor would describe as the resident is going through the exam. Importantly, we're very oh, what's that here? We very deliberately tell the standardized patients to sort of fake it. Obviously, they can sort of pretend that it hurts when you move their when you lift their arm up over their head. You can pretend it hurts when somebody does put some varus stress on your knee, but you obviously can't fake having abnormal deep tendon reflexes in a person who's presenting with concerns for cervical myelopathy. You can't fake having an effusion in your knee. So basically, if the examiner watches the learner correctly perform patellar ballottement, let's say on the knee, then the examiner just says, you find that the knee is ballottable, it's warm, and if they performed a bulge sign, you could sort of describe that they do have a bulge sign with performing the knee exam. So we did not go to the length of injecting normal saline into somebody's intra-articular space in their knee, though perhaps some more creative people would be willing to do that. But this seemed to work very well. After the residents performed the physical exam, they would get immediate feedback. Each station was maybe 16 to 18 minutes long. So there was time to do the exam, get some feedback, maybe practice another maneuver again, and then they would move on to the next station. Importantly, residents were strictly told not to do any counseling. They're not trying to get any more history data. We tell them there is no more history data. This is a physical exam workshop, and the focus needs to be on the MSK exam because that's the thing that is most neglected in graduate medical education is the exam itself. There's a decent amount of time spent on clinical correlation with how gout presents or how adhesive capsulitis presents, but and counseling and maybe even the appropriate diagnostic imaging and management, but very little time spent on ensuring that residents know how to perform these physical exam maneuvers. And so this workshop was very explicitly designed to address that need. So that's what a case looks like. And by the way, at the end of this workshop, I'm going to share a QR code that links you to all of these cases, and you're welcome to use them if you'd like. In addition, the instructor also had a single sheet for each resident that where they could sort of check off which particular maneuvers they performed correctly. So you can see it sort of walks through, range of motion was assessed, warmth was assessed, they performed the posterior drawer, the McMurray. And number one, did they perform it correctly? That would get them an X here. Whereas if they performed it but just kind of botched it, then they would sort of end up here. Whereas if they completely forgot to assess warmth, you would give them the no here. And then likewise for did they arrive at the correct diagnosis before feedback was given? When we were initially doing these workshops, we were trying to study them and look for changes in actual clinical competence. And so we were very deliberate about this scoring tool. Nowadays, since we've already validated these workshops, we don't use this as often as we did before because we don't really need the data anymore because we've been doing it for so long. All right. So this is a sample. Eventually I stopped using a big conference room to do this, and we actually were able to use our clinic. And so the clinic would give me 4 rooms for each workshop that we did for a 2-hour period of time. And so this is an example of a chief resident in the middle there, observing the resident on the left, performing, looks like Jurgensen's resisted supination test for biceps tendinopathy on the PGY3 resident on the right there. We had used standardized patients that were students, but eventually we found it was just a lot less administrative work to just do away with the students and just have residents examining each other. But each resident does assume the role of a standardized patient. They read the case in advance so they can pretend to be this patient presenting with this complaint. So this is sort of a model. We had lots of joint models, of course, to sort of help to facilitate teaching some of the anatomical correlation as we go through. In addition, we made laminated cards, and this is just a picture of three of the laminated cards. So on the left-hand side here, this is the front of the card is the neck exam. The back of the exam card is the lower back exam. We would basically have these printed off. I, tend to make about 100 per year of each one. Um, and in our case, we just used Yale Press here, but you can use any place to just print off these laminated cards. And they were really useful because we would give them out at the beginning of the workshop. Residents would be encouraged to use them during the workshop. I want you to get familiar with this laminated card and all the stuff that's on there. When I ask you which nerve root is involved in biceps flexion or bicep strength, I want you to start to look at the card and start to memorize these things. And same thing with when you're testing the deep tendon reflex at the knee. I want you to know what reflex that is. And so getting people to get comfortable using these cards. On the shoulder exam one, we even included, on the back of the card, some pathology and the sensitivity and specificity of specific exam maneuvers based on the current, the literature on physical exam test characteristics. So those are the laminated cards that we have. And then residents would use those cards, months later. They're seeing a patient with shoulder pain, and they want a quick reminder of what things they should make sure that they do when they're trying to assess whether this person has biceps tendinopathy or concerns for AC joint pathology. They would quickly look at the card, remind themselves and what the exam maneuvers were, and how useful they were. And this is actually a quick picture of actually a workshop coming up in 2 weeks, and it just sort of shows the logistical, different the pawns moving around in time. So we have actually 6 stations. There's case A, case B, case C, case D, and the block in the middle here is where this particular batch of residents is going to sit in front of a computer and go through a quiz that is sort of a content knowledge quiz. So they're having this is actually physical exam maneuver, deliberate practice, and so is this. But for this group in the middle, they're just looking at a series of like 15 questions that are drilling. What does how do you assess for Pes-Answerine bursitis? Where would a person with iliotibial band syndrome typically have tenderness on exam? Those kinds of things to just correlate what they're doing with their hands with what they're doing with their brains. And you can see this involves PGYs, 1, 2, and 3, and I would always have 4 instructors, one at each station. And as you can see, these are about 18-minute blocks, give or take, as they march through the workshop. Logistically, most of the time I'm coordinating the workshop, and I have my 4 instructors in 4 different rooms, and I sort of just walk around from room to room, answer any questions that are coming up, make sure that there's no problems. And of course, if an instructor for whatever reason, God forbid somebody forgets they were supposed to be there, then I fill in, of course, and become, the case B instructor if needed, and I can do that. It's a little trickier to juggle those 2 roles, but I certainly can do it. One of the beautiful things that has happened over the 10 years of doing this is many of our current faculty are graduates of our program, and so they joined as faculty already having a rich musculoskeletal knowledge. And so I knew I could trust them to teach this content well, because I had, I sort of groomed them to have this skill set. And so I can say that across all of our faculty, 15 to 20 folks, if you include, full-time and part-time folks, our faculty they are outstanding musculoskeletal diagnosticians because they've been sort of playing a role in this ethos of musculoskeletal training for, now going on 15 plus years. All right. So again, this is just another picture of this was our program director, John Moriarty, who's now down at UVA, demonstrating the apprehension relocation test for glenohumeral instability. And this is just with 2 residents. And, I encourage the residents, of course, to dress appropriately for the session so that they're exposing their shoulder, or wearing shorts if we're doing the knee one, that kind of thing. To make sure that we're not, having people examine each other through jeans and sweatshirts, which is so counterproductive and not great. So we did publish our findings. We really studied how effective this approach was and found great outcomes in terms of satisfaction with their training, more confidence, even 6 months after the workshops. And importantly, we would test their clinical skills 6 months later. And those who had participated in the workshop compared to those who had been randomized to not participate in the workshop. I'll spare you the actual approach that we took. There was clear, durable knowledge acquisition, which was really what we were trying to do. And we published that stuff also in MedEd portal so that other folks could use what we were doing. So again, that's back in 2015. You can see, and so from 2010 until 2020, that really was what we were doing, and 90% of what I just described is exactly what we're doing today. The difference is this. So in 2020 or 20, yeah, it was right into the pandemic. So 2020, I had a dream come true, which was being invited to work with a professional medical education enterprise company that would create high quality videos and get out of my basement videos to create something that was really gorgeous. And not only is it beautiful, but what I'd always wanted and could not do was embed questions and quizzes throughout the content. I could finally demonstrate myself actually performing the physical exams and have multiple camera angles, really showing exactly what I was doing. And even more than that, was adding like anatomical overlays on the examinees, if you will. So let me just jump into what I'm talking about. So this was released, give or take 2021, and it is honestly, it's one of the proudest things of my entire life. I mean, I love my children. I will still rank them above this workshop or this physical exam course, but this physical exam course is close behind because it really was something I'd always wanted, and finally had a partner to realize it. And so this is the entire physical exam course, but in particular, I wanted to focus on the musculoskeletal component. So when we recorded these videos, they had multiple camera angles, so you could actually look and see me doing, for example, patellar ballottement, which is being shown here with Shayna, was our standardized patient for this particular piece. And then I can do anatomical correlation with joint models coming from a different angle, talking about in here a medial collateral ligament tear. And then Lecturio could add on, like you can see here, like an actual skeletal model as I'm sort of talking about metatarsalgia and just talking about where we're going to palpate when in terms of assessing for plantar fasciitis, et cetera, et cetera. And or maybe I was talking about the anterior talofibular ligament here and ankle sprains. So this just completely galvanized my energy for this workshop series and allowed me to really take it to the next level. So this was YPC Musculoskeletal Workshop 3.0, and that's where we are today. So now my residents get access to the full physical exam course, and they are told to watch the Lecturio videos, and I sort of tell them exactly which ones to watch in advance of the workshop. And of course, all my instructors also watch it so that we're all teaching the same stuff. Particularly with the shoulder exam, you could put 100 different maneuvers out there if you wanted to, but it's important to make sure you don't overwhelm your learners and just provide the stuff that's most commonly the pathology that they're most likely to see and the musculoskeletal exam maneuvers that are most relevant to them. So that's why it's important to have instructors all using the same language and the same maneuvers. And this is our current program director on the left there with two of our residents, also coincidentally doing the Jurgensen's resisted supination test for biceps tendinopathy. This is, I still collect data periodically on making sure residents are enjoying the experience. This just happened to be from literally the last workshop that I did with them maybe a month or so ago. And so I have 15, I guess it's 15, 18 different learners. Participating in this session was a valuable educational experience. 15 out of 18 strongly agreed. 3 said they agreed. And then compared with a week ago, I feel more confident about my knowledge on this topic. And that, this simple data always warms my heart, makes me feel like what we're doing is important. Couple quick comments. What do they want? More MSK workshops. Make them more frequent. We're already doing them. Basically, we do 8 a year, but there's 4 cohorts. So each learner only gets 2 workshops per year. They get Let's say this year it's going to be the knee workshop, which is repeated 4 times, and the spine, neck and back workshop, which is repeated 4 times. In the next academic year, they'll get the hand and foot workshop and the shoulder workshop. And then in their PGY 3 year, or whatever the next academic year, they'll get the first one again. So there's a little bit of spaced repetition that's intentional in there because there's only 4 workshops that we do, 4 different content areas that are just repeated. Um, in theory, I'd love to do them even more often than we do, but it is logistically a lot for me to put these together, and I don't think I could easily do more than 8 a year is what I'm doing. Because, like I said, it's 4 cohorts, 2 workshops. That's 8 workshops a year is enough. These are some great sources that helped me to cultivate my physical exam skills. Stephen McGee's text, which has been updated by other folks since then, on evidence-based physical diagnosis is where I get a lot of the sensitivity, specificity, likelihood ratios, in addition to reading periodic orthopedic literature reviews, where they sort of review the physical exam maneuvers for different musculoskeletal pathology. I made mention of the Stanford 25, of course. JAMA's Rational Clinical Exam Series, which Steve McGee has contributed a lot to those, has a lot of great content on this. And of course, the Lecturio Physical Examination course. I uh, I still routinely, find residents using different, they'll see a patient or they know they're going to see a patient with shoulder pain, and so they just log into the Lecturio site and just quickly watch the review of how to assess the rotator cuff or something like that. And that's been really an invaluable resource for them. When frequently after residents graduate, I'll get emails or texts from residents after they've finished their training, and there's really 2 things that they're um, expressing gratitude for. One is I do a lot of addiction medicine teaching as well, so they're just very, very happy about learning how to manage alcohol use disorder, things like that. But more often than that, it's they're so grateful that they know how to do the shoulder exam, and they just diagnosed a patient with frozen shoulder today, or I knew exactly what I should do for this person who's presenting with patellofemoral pain syndrome. And thank you for ensuring that I learned how to do this stuff. Because once they're actually doing primary care, they realize that this is an absolutely indispensable area of content. And I think that most residency programs are still not providing enough MSK education. And sometimes they don't realize that until their residents are out there in practice and realizing that they're ordering a lot of MRIs, frankly, is what often happens. So this is a QR code for those who are interested to all the MSK workshop cases. So it's 4 folders, and each folder has 4 cases. It has the exam card templates if you were to want to laminate them and print them off. And then I told you that there's a quiz that is used in that sort of middle station that just sort of has a series of questions on different things. This is not made by Lecturio. I also obviously get no benefits from you using those. I really am providing them to all of you because they work. I'm very proud of them, and I want to spread my musculoskeletal education love to the rest of the world. So by all means, you're welcome to use those things. In terms of accessing Lecturio or other content, that I have to turn over to Goran and my other colleagues to discuss that further. With that, you're also welcome to email me if you're trying to access some of those things and are having any struggles, or if you have any questions, or I've even visited a couple universities to sort of get their first workshop going, and I've really enjoyed that. So, not to self-promote myself traveling elsewhere in the world, but just to say, please reach out. I'm happy to discuss further. And with that, I would love to take questions. I think I'll stop sharing my screen.
Yes, thank you very much, Dr. Hall. That was incredible. I have used these resources in the videos, even in North Macedonia and other places, but I feel like I've learned a lot today. So before we start with the questions, some people in the chat currently are asking about the code and how to access the MSK content if they can access it in an email, because they say the QR code is currently not working for some reason. Are you able to maybe post a link in the chat, or maybe post a link to us and we can share it with an email later after the webinar?
Yeah, for sure. I'll make sure we do that, Goran. I did try to make it so that anyone can access it, but there are probably some hospital systems don't allow you to go to Google Drive. So I don't know if that's a factor because it is a link to Google Drive. Um, but yeah, either way, yeah, I can share it through some other platforms as well. Happy to do so.
So before we start with the questions, I just wanted to say I find it really fascinating, and thank you very much for mentioning this during your talk today. We always talk about the effect that the videos and everything we do at Lecturio has over the learners, but I don't think that we usually stop to think what the effect this has over the individuals who actually do the teaching and have the
Oh
ability
yeah.
to share, their education, their knowledge with the world. Because on a global, I mean, I'm from North Macedonia. We've used this here. Like we've seen your
Mm,
videos and stuff. So it does help a global audience to reach something. So thank you very much for sharing that.
I'm glad to hear that.
There are a few questions for you. I have them written down here.
Yep.
So the first is for a program starting from scratch, what would you consider the minimum viable MSK curriculum and where should people begin?
Yeah. Yeah, it's such a great question because I know so for our instructors here, when we have a new faculty member that we recruit for whatever reason, they're oftentimes feeling very behind relative to the other faculty who've been doing this stuff for a while. And so the first thing we have them do is you need to do an MSK workshop as an instructor. And the best way to learn this stuff is to teach it. And it sounds a little crazy, but when they know they're scheduled to run a workshop, boy, do they bone up, pun intended, on their knowledge. They watch the Lecturio videos. I invite them to meet with me if they want to, if they have specific questions, and then, as I said, I like to rotate from station to station during the workshop itself, and I'll spend like the first half of the workshop just with that one person, so that they're building their skill set. So, but we have the advantage of having already kind of some institutional memory, and in terms of this content knowledge, and I feel actually pretty expendable, which I love. I love the fact that I could just go on sabbatical for 6 months and this thing would run on its own. But I know that in a lot of places that's not the case. And the faculty are teaching the residents how to do the exam, but the faculty themselves may not feel super comfortable. So then the residents who will later become the faculty are even less comfortable, and this can sort of perpetuate things. And I also would add that during the pandemic, I think there was even less education devoted to the physical exam because of everyone's fears of hands-on stuff. So I feel like there's this little generation of junior faculty who are particularly behind when it comes to physical exam skills. So, what would I say is the bare minimum? I will say the knee exam is probably a great place to start, the knee and the spine, because the shoulder is so complex. I always say it's the most complex joint in the body, and so I wouldn't go after the shoulder first. And hands and feet are great and they're important, but the pathology is a little bit less common than you might see in the knee. And God knows back pain is the number one most common musculoskeletal complaint. So I would focus on the knee and the spine, neck and low back pain. But incidentally, we talked about having a hip one and an elbow one, and you just got to decide. You got to pick your battles because ideally there should be one on hip pain as well. But start with the knee and try to make sure that you've developed your own skills. I didn't mention this, but I also would go to anytime I went to SGIM or American College of Physicians or any conference that I was going to, I always went to the physical exam workshops. I always went to the learning modules on those things. Because you sort of have to keep yourself up to date. You have to get comfortable with these skills, talk to other people, practice these maneuvers. So really make sure you build your own confidence with these things at every chance that you can get. I would almost every 4 years, I go to a orthopedics in primary care kind of conference run by orthopods to sort of see what the current practice guidelines are about managing hip pain and things like that. So build your own skill set and get comfortable with it. And then I would start with the knee. In terms of the workshop, if you've got access to the Lecturio videos, then you have access to the content to give to your residents. And then depending upon how many residents you have, this is one of the tricky things is if you have a residency program with 150 residents, there's an issue with scale with these workshops, which I fully confess I'm not sure exactly how to address that. My program is 50 residents, give or take, and divided into four groups. That's 12 to 15 residents at a time, which is perfect for a workshop of this size. But if you're talking about cohorts of 35 people, admittedly, that's a little bit more challenging, and you have to decide how to navigate that.
Yes, thank you very much. There's even an audience member. We have this in the chat right now. There's no question, but he has attended
Oh,
workshop.
I know John. Hey,
Yeah.
John. Yes, he did. I was delighted to see him in the chat there.
It's always nice to see, someone that you know like that, right? So there's also, I must say, my first job out of med school was emergency medicine, and I
Hmm.
think that the art of the physical exam was already getting lost a little bit at that point because
Hmm.
we had access, because this was trauma one, we had access to like CT and MRIs and stuff. So you just ship everyone there without even checking something. So especially what you say about the shoulder's more complex. So if you were new and if no one want to drill this or imprint this on you that you need to learn how to do this, you just kind of ship them off to CT. And it's not great because then you're kind of incapable of doing this without
Yeah,
sophisticated equipment around. So I fully agree
and
with that.
yeah, and all those incidental findings that come for the ride. Yeah.
So the next one is how do you address the variability in residents' previous MSK experience, especially when some learners arrive with much more confidence than others?
I mean, I would say that's okay. In some ways, the more seasoned advanced learner is being deputized to, usually they're traveling in groups of three. So there's one standardized patient and there's two residents in the room, and those two residents rotate from station to station, being the examiner. And so if one of them is really competent and knows what they're doing, honestly, all that does is put the heat on the other learner to like rise up, and to realize how important it is to learn this stuff. So it's just like any other content area. You'll have somebody who already has a PhD in in some cancer diagnosis, and so they knock it out of the park when they're on their oncology service, and other people realize, wow, it's really important to learn that stuff. So I don't see any problems with that. It's rare that I've seen a resident have such sophistication in this that the workshop is a waste of their time. I mean, I've been doing this for 15 years. I've not ever seen that. Um, and then I'll also add that sometimes those people who really love this content, if an intern or a PGY2, I'll deputize them to be an instructor in their PGY3 year. I mean, I think that's great to sort of show residents that, if they really dive into this material, they can join the faculty, as an adjunct faculty and be one of the instructors in the room, and then maybe they become a chief resident and they, run one of the workshops, in my absence. And we've definitely had that happen over the years too, where some residents just really develop this as an area of interest, which I love. I love seeing that.
Yeah, absolutely. And I think that it's important to recognize their professional identity from before. So none of them are tabula rasa when they arrive, right? So you see
Yeah.
where the nations lie and where they come. So that absolutely makes sense. We did receive the question back through the Q&A
Okay.
now, so
Oh,
I'm
got it.
glad to say we can address it. So this is from a I can't pronounce physiatrist in a medicine department with a residency program. And the question here is, are MSK issues on the IM boards, so internal medicine boards,
Yeah.
and have you seen any score improvements following the initiation of your program?
That's a great question. Yeah. So, physiatrist, and the 10 out of 10 guy. So, no surprise, the physiatrist actually knows how to do all these MSK things properly, competently, and confidently. It's a good question. So, if you look at the breakdown on the board exam on the American Board of Internal Medicine, it does break it down by oncology and neurology and gastroenterology, and then general internal medicine is where the MSK stuff is, and the general internal medicine stuff is maybe like 10 to 15% of the internal medicine board. And there's just no way you're going to be able to get enough signal from such a small portion of the boards to see did they really get better at the shoulder exam, particularly since, again, huge difference between content knowledge and actual bedside physical examination skills knowledge, which the latter is just not tested on the on a multiple choice test board exam. So that's my long-winded way of saying no. We haven't looked for or seen score improvements since implementing this. It would be tricky to sort of find a signal for such a small part of the exam itself. Great question, though.
Thank you very much. So we have two more. The first one is, do you have any advice for MSK educators and course directors organizing pre-clerkship musculoskeletal education during the first 2 years of medical school?
Yeah. So I direct that here at Yale as well, or I co-direct it with one of my colleagues, Joe Dunrow. And so we use the same content. So there have been times where the Yale School of Medicine did contract with Lecturio to have their content for like a year or two, and then they didn't, and they sort of go back and forth based on how much it costs, which I, of course, have no influence or ability to reconcile. But the way that we do the instruction is similar. We like to do cases, and they rotate from one station to the next. The difference is that you've got 50 medical students in one cohort. There's 100 medical students in each class here at Yale. So that group of 50 will come for 2 hours, and they're really broken up into maybe 8 stations of 6 students. So it's not nearly as much like hands-on. You're going to practice doing the belly off test or something, where you're all going to have a chance to practice it and get deliberate practice and get your skills bolstered in that. It's a little bit more, you're trying to teach the masses here. So it's a little bit less hands-on attention. But they're learning, I think in med school, the most important thing is to really learn the concept of the musculoskeletal exam, the idea of like inspection, palpation, range of motion, strength testing, special maneuvers, appreciating how different joints may manifest with inflammation in different ways. Your shoulder, you're not going to detect an effusion as easily as you would with a knee exam, and sort of appreciating some of those general rules about the musculoskeletal exam, even if they don't walk away being competent, examiners in terms of flawlessly being able to identify a supraspinatus tear on their physical exam. So it's more just making sure they understand the main features. But the Lecturio platform is a great way, a great vehicle, I think, for them to learn those basics and then apply them in a workshop setting. Again, teaching the masses.
Yep. Thank you very much. So we have one more question, unless another one comes in the meantime.
Yep.
So this says, looking back, what is the one thing you wish you had known before developing this curriculum? And what is the first step you would recommend to someone inspired by today's session?
Hmm. Oh man, that's a good one.
It's a meta
Um,
question, right?
yeah, yeah, yeah. Um, let's see. The thing I wish I had known earlier. Uh, I guess the first thing would be it's coming out of residency, not knowing how to do this, um, is not right. I think it took me like a couple years to come to grips with the fact that was inadequate training, and relative to the prevalence of musculoskeletal conditions. And so acknowledging and having all of us who are involved in residency education acknowledge that the current footprint is inadequate for folks going into primary care, I think is an important thing to recognize. By the way, I felt the same about addiction medicine, and that's why I ultimately became an addiction medicine specialist, because all of a sudden I'm faced with people who being referred to me from the hospital with drinking a pint of vodka a day and not really knowing how I should best handle them. That was another skill that I really didn't feel was thoroughly addressed during residency training. And so, it's not right to not be able to handle something that is so prevalent when, boy, I knew how to do a thoracentesis, and I knew how to do paracentesis, and I knew how to, do a lot of ICU care, which is great if you're going and working in the ICU, but so many folks are, I was in a primary care residency program and I still didn't feel comfortable doing these things. So that'd be one thing, is to, if you feel like you're not competent in your physical exam of joint complaints, um, wallow in that feeling and do something about it, because we shouldn't feel that way, and we shouldn't have our residents leave residency training feeling that way either. Because once you do know how to do it, it is a wonderful skill, and it is so important, and patients so appreciate it. Patients know when they're being examined competently. Surprisingly, they can sort of tell that you're moving things around in a certain way, you're doing things with authority, if you will, and you're coming up with a diagnosis. Even if 2 out of 3 times you're sending them for physical therapy, regardless of the condition, you still know what you're sending them there for, what to expect. You can give some anticipatory guidance to patients that I knew I wasn't doing effectively before. And I think the second part of the question was how to start. I think.
Yeah, the second part, let me just open it again. It says, what is the first step you would recommend to someone inspired by today's session?
Yeah. I think look for as many ways as possible to build your own skill set. Like I said, going to national conferences and making sure you find those, the MSK sort of, update, and looking for orthopedics primary care conferences. I find that orthopods, they've obviously have a little bit of a drift towards thinking about, talking about surgical techniques. But if it's like really orthopedics for primary care type stuff, there's a couple that happen just in my area every year. Those are a great way to start to ground your knowledge. And there's plenty of stuff online that's free too. It's not a comprehensive curriculum, but actually a physio tutor is a really reliable YouTube video or a series, and they do a really nice job, I think, of going through one maneuver at a time. So it's hard to get a library of it and assign it, but there's some great stuff that physio tutor has, that you can look for as well. So build your own skill set and start to get some residents excited about it. You'll always find that there's some residents who come to residency excited about sports medicine, and so work with excited trainees, because excited trainees kind of get you excited too. So, say that you're thinking about trying to build a workshop in the residency, and what do you think about that? And do you want to help? Find energy from the people around you who are excited.
Absolutely. Well, I think that's wonderful. And because we don't have any other questions, I think this is a really, really great way to kind of pivot in the next part. And it's exactly, we are at the hour right now. So I would like
Mm.
to thank you very much for taking your time today to come and speak to us. This has been wonderful, and I'm sure that our participants appreciated it greatly. I do have a few slides for the rest of the people on this call, and I will start doing the outro in a second. Dr. Holt, thank you very much. If you have time, you're more than welcome to stay for the next part. If not, we will see you very soon, hopefully. And if there are any additional questions or thoughts or queries from other people, I will make sure that we relay them to you.
Thanks so much, Goran. I'm going to peel off. I got a panel of patients waiting for me right now, but I will, if I can, either right now or this afternoon, I'll send you a link to the videos once I figure out what some of the barriers are. Thanks so much. It's a pleasure to be here. Bye
Right.
bye.
So we did the Q&A session. Thank you very much for participating in that. Now we have created something. You can access a sample of what our MSK content looks like with Dr. Holt. So if you could just follow the link that's written to create an educator account at msk.lecturio.com /register, or you can use the QR code. You can log in and you can access the MSK Learning Path, what was discussed today. So I hope that you can utilize this. I hope you can see it. And if you have any follow-up questions of that, please do let us know, and we can continue the discussion with you so you can get something more for your institution. In the meantime, outside of that, Lecturio has also gotten SimTix. So now you can access SimTix by Lecturio. We have SimTutor here. So if you're doing any form of simulation, we have already pre-created interactive simulations of real clinical procedures. However, there's also the possibility to create your own simulations, including MSK cases, communication with patients, explaining procedures, and everything. So SimTutor is really, really powerful, and it does host AI in the background. So all of this can be very, very particular to your context and to your institution. Please scan the QR code if you want to access some of these interactive simulations and check them for yourselves. And obviously, if you want to know more about this, feel free to get in touch with our team, and we will let you know how you can get more out of SimTix. Lecturia also offers Healer, which is a very comprehensive platform for clinical reasoning created by NEJM Group originally. So there's over 132 cases on Healer for different learners, for different procedures, for different diagnoses, where using probabilistic reasoning, you could create illness scripts and develop your clinical and sharpen your clinical reasoning skills. If you want to learn more about the Healer, please follow the QR code on there. Also, there's also new DO cases here. So I know that most of you in the audience are probably DO or teaching MSK. So Healer would be a really great spot to start thinking more about clinical reasoning. So if you have any questions, if you have any follow-ups, or you want a specific demo for your institution of any part of the suite of three products that we have, then you can always contact us at Learning Science. Or if you need anything specific related to learning science, medical education, any form of research that we might be working on and doing, please feel free to send me an email and I can either put you in contact with the right people or I can talk to you about that.